which is important because the obesity is prevailing in whole world. So please can you give me, so next please. Thank you. Thank you. Metabolic dysfunction associated steatohepatitis. It is a real threat because we are now seeing the hepatocellular carcinoma in patients who never had viral hepatitis, never drank alcohol, or never knew that they have liver disease. This is the new face of liver cancer and it is metabolic. It's the progressive form of metabolic fatty liver disease, which include the steatohepatitis with inflammation and liver injury. And it is mostly linked to the obesity, type 2 diabetes, dyslipidemia, and the metabolic syndrome. 1 in 4 adults worldwide affected. MASLD affects near about 25 to 30% of the adult globally. So there are about 1.5 billion to 2 billion people with the fatty livers. And the MASH prevalence is about 5.27 worldwide, and prevalence rises with diabetes and obesity rates. Recent studies shows that more than 75% of the MASH cases go undiagnosed in the major Western country. I'm not talking about the Pakistan or third world country. Millions in USA, UK, Germany, and France unaware that they have aggressive fatty liver disease. Current diagnosis rate is less than 18%, suggesting the major gap in screening. The complications include the fibrosis, cirrhosis, hepatocellular carcinoma, liver failure, cardiovascular disease, and the extrahepatic cancer. So the definition is very simple. If you have BMI more than 25 and you are diabetic or on the diabetic drug, or your blood pressure is more than 130 by 85 millimeter of mercury, or on medication for the hypertension, plasma triglyceride is more than 150 milligram per deciliter, or HDL level less than 40 for the male and less than 50 for the females. It is associated with 2.2% increased risk of type 2 diabetes, 1.5 times fatal or non-fatal cardiovascular disease, heart failure by 1.5 times, atrial fibrillation by 1.2 times, CKD by 1.5 times, extrahepatic cancer by 1.5 times, and the cirrhosis and HCC risk is 2 to 10 times associated with this MASH. Near about 20 to 30% of the MFLD patients may progress to the MASH, and 2 to 5% of those with MASH ultimately develops the fibrosis. Cirrhosis dramatically increases the mortality and the liver-related complications. MASH is becoming the leading cause of the hepatocellular carcinoma worldwide, with cirrhosis. Annual HCC incidence is about 1 to 3% per year, which is comparable to the viral hepatitis-related cirrhosis. Without cirrhosis, though, the risk is low, but the significant population burden, 20 to 30% of the MASH-related HCC occurs without cirrhosis. Projection shows that the MAFLD-related HCC rising sharply through the 2030, and among the existing HCC cases globally, 48.7% have metabolic dysfunction-related disease. Hepatocellular carcinoma is the 6th most common cancer, but it is 3rd leading cause of the cancer-related death due to the late diagnosis and the aggressive nature, and over 900,000 new cases are reported each year globally. And the mortality is quite high with 800,000 deaths annual. Highest burden occur in the East Asia, Southeast Asia, and Sub-Sahara African countries, and the MASH are projected to be the primary cause of the liver cancer in coming decades. Diagnosis is very important, and the most common are the non-invasive procedure and then the liver biopsy and serum biomarker. Among the non-invasive diagnostic tools of the MASH, the most common is the fibroscan, which is also known as transient elastography. It is the state-of-the-art diagnostic device designed to assess the liver stiffness. It is non-invasive, quick, painless, and repeatable. Basically, it is the vibration controlled transient elastography which produces the shear waves, and these shear wave passes through the liver. More the liver is stiff, there is more speed of this shear wave, and upon the speed of the shear wave is directly related to the stiffness of the livers. And other important tool is the MRI, which is the magnetic resonance elastography. It is the non-invasive, painless, and more accurate than the traditional liver biopsy, and can detect the fibrosis and early stages of liver fibrosis. This is the Metaver score, which is most commonly uses. F01 is the mild fibrosis, F2 is the moderate, and F3 is the significant fibrosis, and F4 is the cirrhosis. MRI proton density fat fraction is also an advanced MRI based technique. It quantifies the exact percentage of fat in the liver tissue, not just the visual grading. And the most common are the non-invasive diagnosis tools are the scores, which are the NAFLD fibrosis score, which requires the age, BMI, diabetes, AST/ALT ratio, platelet, and albumin. If the score is low, mean less than minus 1.67, it excludes the fibrosis. But if the score is high, more than 0.675, then it shows the advanced fibrosis. And the most important is the FIB-4 score, which requires only the age, AST, ALT, and the platelet. It is the simpler and widely used, and I will explain it in the next slide. APRI score is the very simple, which is the AST to platelet ratio index. It includes only the AST and platelet counts, and if its score is less than 0.5, the chance of fibrosis is very low. And if its score is more than 1, then the chance of fibrosis is quite high, and if the score is more than 2, it is the advanced cirrhosis. So it is the algorithm. If FIB score is less than 1.3, you only reassure the patient and repeat it after 1 year. If the score is between 1.3 to 2.67, you go for the fibroscan. If the fibroscan score is less than 8.8 kilopascal, then you only treat the comorbidity. But if the score is more than 8 kilopascal or liver is stiff, you refer it to the hepatologist. Liver biopsy is a gold standard, particularly for the research purpose, and liver biopsy is the definite non-radiological diagnostic tool. Finding in MASH is the steatosis, ballooning degeneration of the hepatocyte, lobular inflammation, and fibrosis stages. Treatment, the most important is the lifestyle modification. If you lose more than 10 kg of body weight, it definitely regresses the fibrosis. Diet, exercise to reduce the fat and inflammation, control the diabetes and the lipid profile. And regarding the pharmacological treatment, the most common is the GLP-1 agonist. It is mostly used and it is the first line pharmacological choice in patients with MASH plus obesity, MASH with diabetes, or in the earlier stages of the fibrosis, 0, F0, 1, 2. Resmetirom, it is the thyroid hormone receptor agonist, is also approved for the MASH. SGLT2 inhibitor also have promising effect in the liver fat. So, all the patients with MASH who develops cirrhosis should undergo HCC surveillance every 6 months with the ultrasound plus alpha-fetoprotein. HCC can occur in MASH even without cirrhosis, but surveillance is recommended only once cirrhosis is established. Undiagnosed MASH results in billion in lost productivity and healthcare costs. Early detection and prevention reduce the long-term cost.